Good morning, everyone. Welcome to today's Thyroid by MD's webinar session. My name is Camilo Gonzalez-Velazquez, co-host of the Thyroid by MD's webinar series, and I'm delighted to host this event today. Today, we're honored to have Professor Dr. O'Keefe presenting a lecture on responsible artificial intelligence in thyroid disease. Professor Derek O'Keefe is a distinguished physician here, holding dual first-class honor degrees and doctorates in medicine and engineering, along with several gold medal awards in science, technology, engineering, and mathematics, as well as first-class honors MBA degree. His remarkable achievements include being a Fulbright Scholar at Harvard, a Green Tempton Scholar at Oxford, and a graduate of endocrinology clinical fellowship at Mayo Clinic. Dr. O'Keefe has multiple academic publications, biomedical patents, and international research prizes to his name. Notably, he has worked with the NASA, placing a sleep experiment on board the International Space Station, serving as flight surgeon for the Nemo Aquarius mission. He is the founder and director of the Health Innovation via Engineering Hive Lab, which focuses on developing patient-centered solutions to clinical problems throughout interdisciplinary collaboration. Professor O'Keefe is currently a consultant physician endocrinologist at the University Hospital in Galway and professor of medical device technology at the University of Galway. Additionally, I am delighted to present Dr. Guillermo Elizondo-Riojas. Dr. Elizondo is an interventional radiologist and professor at the Universidad Autónoma de Nuevo León in Monterrey, Mexico. He is former chair of the Radiology Service and has also served as academic secretary of the Universidad Autónoma de Nuevo León Medical School. He has published extensively in the field of radiology and interventional radiology in high-index journals, and he is the author who initially described the growth of the pituitary gland in pregnancy and Sheehan syndrome in vivo. Dr. Elizondo currently serves as the director of research at the in the Universidad Autónoma de Nuevo León, and is the coordinator of the Education Committee of the Mexican Federation of Radiology and the chair of the RSNA Committee on International Radiology Education. He is a highly esteemed professor in the field in Mexico and Latin America, and he's also a personal mentor of mine. I can say that this webinar is one that I've been long waited to have the privilege to host. With no further ado, Dr. O'Keefe, the mic's all yours.
Great. So thank you very much for the invite to speak today. I'll be speaking to you about responsible artificial intelligence in thyroid disease, which is a very exciting topic, which I hope you'll learn a lot from after this presentation. So just to start off, we were going to call this RAI in thyroid disease because we all know that RAI is a treatment in thyroid disease, radioactive iodine, and that's a good way to make people think about the new RAI in thyroid disease, which is responsible artificial intelligence. And as you heard, I'm a professor, a consultant, and attending physician here at the University Hospital Galway in Ireland. And I'm also the professor of medical device technology at the university, a co-located campus. And I'm the national program director in Ireland for diabetes, another important endocrine condition. And I am a physicianeer, which means my training encompasses both engineering and medicine. So when I first started my academic journey, I did a degree in electronic engineering because I wanted to figure out how things work inside in technology. Then I did a master's of computer engineering and then a PhD in biomedical engineering. And I went to Boston then to do a postdoc at Harvard and worked with some remarkable people there who did what we call in Europe graduate medicine, but in America it's just called medicine because you must have done a degree in something else before you do med school in America. And the people I worked with there had done engineering, for example, at MIT, and then had done medicine at Harvard afterwards. And those physicianeers that I worked with had this really interesting skill set between engineering and medicine. And engineers are problem solvers, they're solutions orientated, they think in black and white, obviously. Whereas medicine, any of us who are on this presentation that are clinicians, we know that nothing's ever black and white in medicine, and it's a spectrum of color is what we deal with different patients, and there's lots of clinical problems. So if you have an engineering mindset and you have lots of clinical problems, it gives you a real opportunity for innovation. So I did a lot of my training both in Ireland at the University of Limerick, in Galway, in Oxford, at Harvard, and then at the Mayo Clinic. So when I finally got my permanent job here in Ireland in 2018, my father cried. He was so happy that I was finished university. And I've been here since, and I've gone back and done an MBA to learn a little bit more about healthcare from a different perspective. So I'm a physicianeer is the best way to think about that. Another thing I like to do besides my academic work and clinical work, which I'm very passionate about, is one of my hobbies is wildlife photography. And this is the great grey owl, a beautiful bird that lives in the northern latitudes called the Phantom of the North, lives in the dense forests of the taiga, or the northern forests of Europe and the Arctic. And you've got to plan a lot how you want to, see a bird like this. You got a lot of logistical planning to do. But one of the most important things you do when you're going looking to take a photograph of a beautiful bird like this, and so it's the biggest owl in the world. It's about the size of a Labrador, and it comes out of the forest really quickly and then disappears back into the forest as it's hunting for prey. You really need to think about the lens you're going to use on your camera to take the right shot. And that's really important in life as well when you're looking at different problems, the lens you use. So I use an SLR camera. It's a mirrorless camera now these days, and you can attach different lenses onto that, and you put the wrong lens on it and you're just going to get the whole forest and the bird will be a little dot. You put too long a lens on it and you're just going to get the beak of the bird. So you need to get the lens right for the problem you're looking at to make sure that you have the right solution. And I think that's very true in healthcare as well, and especially a topic like we're talking about today that's across a couple of disciplines. So if you think about when I'm working here in the hospital and I'm told, for example, that there's a patient in the emergency department that has a cut on their leg, and I go down as a physician to see what's going on with the patient, because we also do general medicine here in Ireland. So I go down as a physician and I say, yeah, this person has a cut on their leg. We need to clean the wound, we need to dress the wound, and we need to give them an oral antibiotic to prevent the infection that started in the wound. That's what I'm thinking about as a physician. That's my lens to the problem. As a biomedical engineer, when I'm in that situation, I'm saying, I wonder, could I put the antibiotic into the bandage? And that way then you'd have local effects of the antibiotic targeted at the site and you'd avoid the systemic effects. But then when you go down and you think as an MBA lens, you're saying, why is this person even in the emergency department? They should be perhaps at an urgent care facility in the community. And those three different lenses are really important to see different views on the problem. So as I mentioned, I live in Ireland, in Galway, and for the international members that are on this presentation, Galway is a beautiful city in the west of Ireland, on the west of Europe. It's by the ocean. We call it the Silicon Valley of Ireland because there's a lot of med tech companies here. One of the interesting things about the city is that Christopher Columbus came here 2 years before he went to discover the New World. So we've got commemorations to Christopher Columbus around the city. And the university that I work at here, the University of Galway, it's here almost 200 years. It's a beautiful quad-inspired building for those who ever get a chance to visit us here in the Emerald Isle. And this looks like the kind of place that Harry Potter would go to college. And it really is a lovely place to study and to work in. And as I mentioned, our footprint internationally is significant, especially in the digital realm. So Ireland only has a population of about 5 million people, but that's equivalent to the city of Barcelona maybe. But our international footprint is quite significant in the digital space. So we have all of the top 10 med tech companies in Ireland, and we have all of the top 10 IT companies in Ireland, or the ICT companies. And that's really impactful because we make a third of all the contact lenses in the world. We make a quarter of all the injectable devices for diseases such as diabetes. We make 50% of all the ventilators and ICU in the world. So when COVID happened, a lot of people looked to our country. We make 75% of all the orthopedic knees. A very significant med tech world in Ireland, and especially here in Galway where I work. And then also on the IT, we have the Alphabets or Googles, the Facebooks, the Amazons. They all have set up here in Ireland as well. And that mix gives us an awful lot of opportunity to innovate in this space that we're talking about today. I actually work as a doctor in the hospital, as I mentioned, so I'm an attending here at the University Hospital. This is my clinical team. And then, as you heard, I set up in 2019, when I established my practice, Health Innovation via Engineering Laboratory. And what that basically means is I took my inspiration from nature. No one honeybee can make honey. It has to be collaborative. And you have to have lots of people working together to achieve a bigger outcome. So while I have expertise in engineering and medicine and business, I don't know everything about those disciplines. And it's very important to remember that, and also to collaborate with people outside of your disciplines. So in our lab, we have about 25 people from across a range of disciplines collaborating on some very interesting projects, people with computer science backgrounds, educational backgrounds, statistical backgrounds, and so on. And so I put this picture up first because, this is really important to acknowledge all the great people I've worked with at my lab in the last 5 years. We've achieved multi-million euro funding, and we've got publications in the big academic press, both medical and engineering. And we've done some projects which have been impactful, which is really nice. So back to today's topic, I'm going to talk about responsible AI and thyroid disease. It's a really interesting topic to talk about. Thyroid disease is a big problem, as we know, for the thyroidologists that are on this meeting. And responsible AI is something that's emerging very rapidly, both in the literature and in the industry, as something we need to be cognizant of. So you might be wondering why we need to have talk about responsible AI. And the best way I can summarize that is I've asked one of my colleagues to talk about it, and this is one of my friends, Barack Obama, and he describes why we need to talk about responsible AI really well.
Hi, Derek. This is Barack Obama. I just want to say I am a big fan of you. I hope I get to meet you.
So clearly that's not Barack Obama, and it's one of the reasons we need to talk about responsible AI, because AI has the ability to do really powerful things with data, and we need to be cognizant of the framework that we need to set up to make sure that we do it responsibly and ethically and so on. So back to the thyroid again. So as we know, it's a butterfly-shaped gland that sits in your neck, and it's got the responsibility of producing hormones that dictate both metabolic rate and also growth. Interestingly, it produces 3 main hormones, so T4, T3, and calcitonin, and it gets its name thyroid because when the early anatomists looked at it, it saw that it was, as I said, kind of a butterfly-shaped gland. And then an anatomist in the 17th century said, that looks like the ancient Greek shield, which was called the Thios. And you can see here an example of a Greek coin from that era, about 2,000 years ago. And you can see it classically represents the 2 lobes and the isthmus in the middle. And when we think about thyroid disease, I think it's important to classify that we're talking both about the functional disease, so a problem, for example, with the output of those hormones that I mentioned, the T4 in particular. So is there too much of it, hyperthyroid, or too little of it, hypothyroid? And then also, for example, with the structure of it. So is it an abnormal growth like a goiter? Is it a nodular growth that could be a benign lesion or a cancerous lesion? That's the way we think about thyroid disease, between kind of the laboratory metabolites and then also the structure of it with the nodules and the cancer or benign workup. And again, just for impact, what we're talking about today, you're looking at about 200 million people on planet Earth have thyroid disease. And so the population of planet Earth is somewhere around 8 billion. So you can see that's quite a large percentage, maybe 3-4% of the population have a thyroid problem. And that's really important, just to put context of what we're going to talk about and why AI in this field can have an impact for a lot of humans on planet Earth. So the next thing to talk about then is data. So what do we understand when we think about data? So when we think about data, most people think about data with this kind of a feeling. And this is data that we think about, for example, from the movies, where you have data related to sound. But we actually know in real life data isn't that exciting. So data is actually just a collection of facts or measurements, just bundled together, just raw data that's just collected. And one of the take-home points from this talk today, I hope that you realize, is that data is everywhere. And that's really important, especially inside the human. So this talk today, we have data around, for example, how many people are on the call, what the presentation is, the layout of the slides, the bit rate of the presentation across the bandwidth, and so on. Data is everywhere, and we can harvest data everywhere, and that's really important. But when you think about data, you need to understand what kind of data you're collecting. And the best way to describe that is it qualitative data or is it quantitative data? And in each of those categories, is the data you're collecting ordinal, nominal, discrete, or continuous? So you need to have that baseline understanding of what data is before we move forward up the architecture of big data and AI. And another thing I like to talk about when I speak about data is very small amounts and very large amounts, small and big numbers of data. And that's something that medical professionals aren't often exposed to in their training, whereas scientists often, people working in medicine might be, milligrams or micrograms or maybe picograms when it comes to lab measurements, but usually nothing smaller than that. And then same on the other side with kilos and mega. That's the range of their kind of understanding of data. And even as humans, we don't have a very good understanding of data, in that we normally have a good understanding of data that we can physically interact with. So if I was to say to you, if you saw a crowd of people and there was 10 people in it, you'd say, okay, I can count 10 people. That looks like 10 people. Would you be able to visualize maybe what 100 people looks like? Or 1,000 people? What would 1,000 people look like in your mind? Can you get a sense of that? Or if I said 100,000 people, what would that look like? And so you're starting to try and find anchors for that number. So 100,000 people might be you attending a large sporting event like a Super Bowl, or maybe the population of the city you're living in. If I said 1,000,000 people, would you kind of understand what that means? Or if I said 1,000,000,000 people, like I just mentioned, the population of the planet is 8 billion. Humans aren't very good at big numbers. And I think that's an important thing to understand when you're starting to get into the world of big data and what that actually means. And one of the best ways I've seen to describe big numbers, to give us a better mental shortcut onto what that means, is to think about your heartbeat. So your heartbeat beats about once a second. So we have a really good understanding of, what a second is, roughly 60 beats a minute. So if you think of the number 1,000,000, so 1,000,000 seconds or 1,000,000 heartbeats is roughly 12 days. 1,000,000,000 seconds or 1,000,000,000 heartbeats is actually 32 years. And 1,000,000,000,000 heartbeats or seconds is 32 millennium. And that's a really powerful example of the difference between 1,000,000, 1,000,000,000, and 1,000,000,000. And you need to understand and conceptualize that if you're going to understand what big data means. That's really important. Another way of thinking about it, again, is this third rock from the sun that we live on, called planet Earth. The universe that we live in is about 13 billion years old. So now you have an understanding what billion means compared to million. So 13 billion years the planet is here. 500 million years ago, so 500 million, is when life started on Earth, the so-called geological Cambrian explosion. And then about 250,000 years ago, so that's the kilo measurement, the 250,000, that's when hominids first started to appear, or at least, sorry, Homo sapiens. Hominids have been here for about 5 million years per the fossil record. So about 250,000 years ago, Homo sapiens, or modern humans, evolved. And then about the last 10,000 years, we've had agriculture. So that's another way of thinking about the scale of numbers, and that's really important. And just to say as well, if you think about wealth, the richest people on the planet are probably Jeff Bezos and Elon Musk, and they have about 200 billion in money. They don't have the trillion value yet, so 200 billion. And that again shows you how big a trillion is. And that's really important, I said, to conceptualize what is big data. So when I did my computer engineering training, we learned about the 3 V's of big data. So we learned about data volume. So again, you have mega, giga, tera, peta, which are the different multiplied by 1,000 each time the volume. And so that equivalates to a millionaire, a billionaire, trillionaire, and a quadzillionaire. So that's huge amounts of discrete things or numbers. We talked about data velocity for big data. So do you collect the data in real time, near real time, or periodic? And then we talked about data variety. So the type of multimodal data you collect. So is it, for example, photos, videos, audio, text? They were the 3 core V's. When I went back to do my MBA about 15 years later after my computer engineering training, other V's emerged that was very interesting to look at, such as veracity of the data, the value of the data you're collecting, and then the variability of it. So that's what you need to think about when you're thinking about big data. And medicine inherently has a lot of data, a lot of big data, because you're at that trillionaire, quadzillionaire, the giga, the peta data that you need to collect to see the whole encompassment of healthcare. And that's things like what we would see as clinicians, the health record, the lab data, the radiological data, but then all the other stuff that's collected as well, such as medical claims, patient registries, genomics, obviously. So there's a lot of big data in medicine. And as a clinician, we normally deal with 2 or 3 data points when we're interacting with the patient, maybe their T4 value, their TSH value. Very soon in our practice, we're going to be dealing with, billions of data points when we're talking about people's genetic codes and using that, or at least the variability that they have in conjunction with those 2 or 3 metrics that we use in thyroid care or in diabetes care. We're going to be looking at people's genetic profiles and risk factors as well as we move forward in this decade. The problem with all this data, of course, is it's like trying to drink from a fire hose because there's just so much of it. So how are you going to have a meaningful clinical interaction if you have all this data to process? And one of the good things that's emerged in the last couple of decades is this whole field of data science, which leans on mathematics, it leans on computer science, and then domain expertise. So in this case, in medicine, they would look to clinicians to contextualize how to use the data science tools in that field. And that's really important because, as I said, there's a lot of data out there, and data is just raw factoids. And so data science allows us to take that data, sort it, arrange it, and present it visually. And the presenting visually of the data is really important because then we can take it and move through what's known as the DIKW triangle to go from data to information to knowledge to wisdom. And that's really where we get the most value from that data when it's actually put in a format that we can gain wisdom from. And again, a good example of this is diabetes. In diabetes, we collect 300 values a day of a patient, for example, with continuous glucose monitoring. If they haven't seen them in a couple of weeks, that's a lot of kind of data to look at. And so the diabetes community has done a good job in the last 5 years of developing the tools to integrate that data to allow you to see it in a very meaningful way to then have a rich discussion with your patients. So I'm highlighting this to show there's lots of opportunities in thyroid disease to use data science to improve how we interact with patients, because most of us in clinical practice with thyroid, especially on the functional side, when it comes to laboratory values, this is what we see. We see a value, we make a decision about, increasing an anti-thyroid drug, or indeed L-troxin or levothyroxine, and it's a point in time. Or maybe we have a tabular format of a couple of TSHs and T4s over the last few weeks and months. We're not that good in thyroid disease yet at presenting the data visually, to see the data trends, to see the prognosis of where the data is going, to pick out the ability to see what that thyroid function will look like in 6 months or a year based on all the historical data from that patient and other patients. And that's why it's such an exciting time to be in thyroid disease research now, because there's a lot of opportunity to use those data science AI tools in this space to both present information differently, for example, graphically, and then, as I said, even just to graph the data and then to use the AI tools to come out with interesting trends data, both from the thyroid values, but as you'll see later on, from other metabolites in the blood, for example, or indeed other data collected from the human body. So thyroid function data, that's the way we do it at the moment. A lot of room for improvement there in research, and then to operationalize it, to roll it out into clinical practice. And then in thyroid structure data, most of thyroid, obviously we can use CTs and other types of radiology. But when we think about thyroid structure data, most of us in clinical practice are talking about thyroid ultrasounds. And in thyroid ultrasounds, we get a picture that we take a static picture from it. We look and we use that picture to decide, for example, the malignancy of that nodule based on characteristics of the nodule that's been identified to decide, for example, if a biopsy is needed or indeed surgery. And I think one thing to point out here that the thyroid field hasn't really embraced yet, but again, another great opportunity for research, is that the data we can collect isn't just a static image, it's actually video data. And as the technology has matured and we can store video files, feeding that big data of a video file rather than a static image into a machine learning or a deep learning neural network, that's really important, because that gives a much richer picture of what's going on, and we'll be able to get better prognostic indication from that, because deep learning depends on the laws of small effects, which we'll talk about in a few minutes. Okay, so that's where we are at the state of the art with thyroid disease and data, both the lab and then the actual structural data from ultrasounds predominantly around the world in clinical practice. So is data valuable? Why are we in the age of AI? The answer is we're in the age of AI because 20 years ago, and you can see from this graph here, it's the richest companies in the world, the market capitalization. 20 years ago, the richest companies in the world were the oil companies, the hedge funds. And in 20 years, what's happened is something quite remarkable, that the most valuable commodity on earth now isn't gemstones or petroleum, it's actually data. And so the Alphabets, the Facebooks or Meta, the Googles of the world, the Amazons, the Microsofts, they've become the most valuable companies in the world because data is valuable, because they can use data to target, for example, advertisements to you, and to make suggestions for you to promote financial transactions. And the reason we're talking about in 2024 is we're at a time whereby the processing power is strong enough to allow us to use algorithms that we only ever sketched out before. So for example, if you were to look at the progression of processing power, here you can see the Intel microprocessor, how it's gone in the 1970s, its output of bits per second, to where it's going to be by 2030, you're going to have 1 trillion transistors on a single integrated circuit. And again, that's remarkable. And I'll just, again, in your mind, go back to the example we had earlier, the difference between a million, a billion, and a trillion. So a trillion, we said, was 32 millennium. We mentioned that Elon Musk and Jeff Bezos have about 200 billion in money, nowhere near a trillion, you know. And so a trillion is a huge amount of gates on a transistor to have. And that allows us both to process data quicker and then also to store data. So we really are living in the age of AI, and we're in what I call a digital Cambrian explosion. We talked about the Cambrian explosion earlier for geology, when life suddenly flourished on Earth. We think it's because there was enough oxygen at the time to support higher levels of life. But we're in this digital Cambrian explosion whereby we've got so much processing power in that smart computer in your pocket, the phone, and not only is it a supercomputer in your pocket, it's connected to lots of other supercomputers through 5G networks and the internet, and that leads on to cloud computing and so on. So it's a remarkable time for AI, and that's why AI was first discussed and discovered in the 1950s, but it's only now it's becoming clinically relevant because of the processing power and the age of AI that we live in. And part of that discussion about artificial intelligence revolves around this man who hopefully you know. He's in your pocket right now. This man and his company is the biggest AI company on planet Earth, arguably. His name is Sundar Pichai, and he is the CEO of Alphabet. And he gave a talk recently about what the goals of Google are for the next decade. And it's about a 20-minute talk, and I don't have 20 minutes to play it all to you, but I'm going to give you 10 seconds of his 20-minute talk of what he spoke about.
AI, generative AI, generative AI, generative AI, AI as AI, 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 AI. It uses AI to bring AI, 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 AI.
So you can see what's important to a company like Google. Artificial intelligence is the answer. It's the same in Microsoft. It's the same in Amazon. It's just the same in Meta. All these companies are focused on AI because over the last 20 years or so, they've harvested large amounts of data, and AI gives them the ability to process that data and to produce really interesting outputs. I need to say at this point, though, when we talk about artificial intelligence, most people, back to my earlier example of data with the matrix rain and the sound, most people think of the cinema. They think about artificial intelligence like almost the Terminator, like a super intelligent robot that will wipe out humanity. And we're not there yet, okay? If we'll ever get there indeed. Because where we are when we talk about AI is that first box here. There's 3 boxes of AI. There's artificial narrow intelligence, which is also just called machine learning, or also just called statistics. There's the middle box, which is artificial general intelligence, and then the one on the right, which is artificial superintelligence. And you can see from the slide here the differences between them. So artificial narrow intelligence is essentially pattern matching, where an AI is trained to do a single task. Like, for example, on your YouTube algorithm, when you're listening to a song, or on Spotify, and it suggests a song for you to listen to afterwards. And you're like, oh my goodness, it really knows me. And it really knows you because it's been listening to your listening pattern and comparing it to millions of other people like you, and then suggesting a song to you that you might like based on your musical listening habits. It's just pattern recognition. And that's where we are now when we talk about AI on planet Earth. And that's the same in medicine, as we'll talk about in a second. Machine intelligence is the middle box, and that talks about a computer that's as smart as a human across the board, so it can do many of the same functions as humans can. And you've got to remember, the term artificial intelligence as an umbrella means everything a human can do, and we can do far more than pattern recognition. Okay, we've got vision, we've got movement, we can create things, we can deduct things, we can reason things, we can do far more things than just spotting patterns. And that's why it's really important to know the difference. And then the last one then, which is machine consciousness or machine superintelligence, that's an intellect that's much smarter than us across the board. And we're nowhere near that yet. So where are we now when you look at the picture? This is a really nice picture after all we've talked about so far. So you have that artificial intelligence circle, which, as I said, is vision and movement, as well as pattern recognition, which is an important part of intelligence, but not all of it. And that's called machine learning. And so in machine learning, then a subset of it is deep learning, which you've heard a lot about neural networks and so on. And then on the other side, you have this data science area, data analytics, which a lot of us have used, obviously, in our science. And then this idea of big data, which kind of branches both areas of data analytics, data science, and then deep learning. And all this data that we've collected, and because we have this processing power I've told you about, we've had the ability to operationalize neural networks, deep learning. But essentially the challenge with it is that it's a black box. You give it an input, you get an output, but you don't really know what's happening in the middle. And that's been a major ethical concern of deep learning and artificial intelligence, to use the generic term again, for the last few years. Now, the good news is that we've managed to develop some tools such as explainable AI, which I'll talk to you again about in a few minutes. But that essentially allows us to put a mathematical algorithm on the black box and get, for example, a heat map of how the input is generating the output. What's the model doing to make it make that decision? So, for example, there's good examples in the literature of, for example, a hospital in the US that trained a data set to spot if there was a clot in the lower leg, and it did it really well, you know, when it gave it thousands of images of clots in the lower leg and a control of thousands of images of not clots in the lower leg, or DVTs. And then when they trained it on data from the hospital when they trained it in the hospital data, it worked great. And then they gave it more data from the hospital the following few months, and it worked great. But then when they externally validated it with a different data set outside that hospital, it actually performed really bad. So maybe in the hospital, it had a 90% accuracy, as good as a consultant radiologist. But suddenly when they trained it outside or used it outside the hospital network, it was down to the 20s, 30% accuracy. And they couldn't understand why. I mean, it worked so well in this hospital network. And when they went back and they used explainable AI to look at what the model was doing, it turns out that the model was looking at the ultrasound image, and the radiographers in that hospital used to put an X where the clot was. So the model just took a shortcut, and anytime there was an X on the image, they said that was a clot. And therefore, that was obviously a surrogate for where a clot was. And therefore, when data was used outside of that hospital network, where the radiographers weren't trained the same way and there was no X's present, it wasn't able to identify a clot. And that's the real heart of our concerns about using AI in medical practice. We have to understand how it comes to its outputs, or we have to put in the framework there to give us as many assurances as we can before we deploy it. So when you think about artificial intelligence, I want to just take it back again. You're talking about machine learning, you're talking about deep learning, you're talking about pattern recognition. So this is the famous one where we teach our medical students and our biomedical engineering students muffins or chihuahuas. As a human, you can look at this. One of your abilities is to pattern match, and hopefully you can see which one is a muffin and which one is a chihuahua. And clearly there's a difference, because if you bite the wrong one, you're in trouble. And if you feed 1 million images of a chihuahua and 1 million images of a muffin into an algorithm, you can train it to have a very good accuracy the more good data you give it. And that's essentially what it is. So when an AI or machine learning or a neural network comes out and says, yes, this is a chihuahua, and it gets it right 99% of the time, everyone goes, oh my goodness, this machine has consciousness. But it doesn't. It's just really good at understanding the pixels in the picture. It does know what a dog is conceptually. It's never licked its hand. It's never gone for a walk with a dog. So that's really important to bear that in mind as well when it comes to machine learning. And AI is impacting all areas of our lives, right? So from smartphones to social media platforms to commerce to vehicles. But actually, when you think about the AI impact on planet Earth, very little of it is in healthcare, and very little of that then is in thyroid disease. So when we think about AI in healthcare, what you're thinking about are the big impacts in the last 5 years. A great study that was done that's looked at retinas, and not only could see retinal disease, diabetic retinal disease, but could also tell you the sex of the patient and cardiovascular risk factors about the patient. That's phenomenal. There's no consultant on planet Earth in ophthalmology that can look at that fundal image and tell you the sex, but the AI can. With the ECG, it was also done recently. We can all look as clinicians at ECG and tell you if there's cardiac damage, but you're able to train an AI to tell you the age of a patient based on the ECG. And more recently, they looked at echocardiogram videos, and again, not just being able to tell you the ejection fraction of a video, but being able to tell you really interesting thing about the metabolites of the blood. They could tell you if somebody was anemic or not based on their echocardiogram. So finding data, small effects, as I mentioned earlier, that we can't see with our eyes, because as humans, we see large effects, not small effects. So collecting enough small effect data to nudge the probability to say this person has anemia or not. So when we look at thyroid disease and where the impact has been with artificial intelligence, I'm delighted to say in the last 5 years, equally, there's been an explosion of really good research in thyroid AI. Many of my colleagues, both from Mayo Clinic and beyond, Dr. Maraca, Dr. Singh Ospina, Professor Brito, Dr. Tora Tobin, many of these people have done really exciting research, both in image analysis, in natural language processing. In fact, this year at the American Thyroid Association, Professor Brito organized a really interesting panel on AI in chatbots for thyroid disease. And Johnson Thomas has done a great job. I have a reference there, writing up that particular meeting that we had and discussion that we had about AI and thyroid disease. And Johnson Thomas himself has done fantastic work in AI. So really good people are emerging in this field in thyroid, which is really good to see. And one of the things we talked about at that meeting was these risks, that bias, as I mentioned. You need to be careful because this AI doesn't just tell you your next song. This AI might diagnose you with a thyroid condition, or indeed give you a prognosis of a thyroid condition that leads to different treatments. And then there's issues around privacy as well, as we mentioned, and security issues of that data. So there's profound problems with big data in healthcare, and that data then feeding into AI that we need to be cognizant of when we're developing these systems. Biased data sets, as I mentioned earlier, something like simple as an X in a radiographer's report, or for example, using skin color data from Caucasians in Northern Europe and then rolling out the dermatological AI tool in Southern Africa. So that's really important as well. What population you trained your data on and where you're going to deploy it, hallucinations in the data, and then garbage in, garbage out. So the internet, as you know, is a wonderful tool that we all use. However, a lot of the internet is garbage. And we know this because if you were to type into the internet, when was running invented, it would tell you it was 1784, and it was invented by a British man called Thomas Running, who started to walk twice as quickly as everyone else, and everyone said, oh, look at him, he's running. Now, this is completely garbage. Obviously, someone just put this website up for fun, but we've been running since the plains of Africa, 10,000 years ago. But because that information is on the internet, when, for example, a large language model goes out and scrapes the internet for information, it pulls that and it thinks it's real because it hasn't been validated. And that's an important step in medical AI. It has to be validated. Same, for example, scarab beetles. So like someone wrote a website, complete garbage, saying that scarab beetles are the reason the pyramids were built, because scarab beetles have anti-gravitational effects and they could float the big stones to the plains of Giza. That's not true, but obviously when a large language model scrapes that, it takes it as fact. And so that leads us on to what is responsible AI. And it's a new way of thinking about AI. It's not just from a computer science point of view. It's because we can see the profound effects of AI across the planet, across domains, and in particular in healthcare. Responsible AI is developing a set of practices that ensures that AI systems are designed, deployed, and used in ethical and legal ways. So you can read about, for example, the COCO experiment that was done in the last few years, where an AI was developed and trained to give mental health advice to people in an unethical way, because the people weren't told that they were interacting with an AI robot. And so computer scientists aren't really trained in, ethics like the Belmont principles that clinicians are, or indeed scientists are. And in some jurisdictions, it isn't a legal requirement to follow an ethical principle. And that's something we need to think about for governance going forward. But this framework that's been proposed by multiple companies, the Microsofts, the Googles, it's about responsible AI framework in its development. So when you're going to sit down to develop an AI, you're thinking about data governance, you're thinking about your model development, you're thinking about your model validation and testing. You're thinking about once you actually roll out your model, how are you going to monitor its effects and the feedback from it? And then, as I mentioned, governance, be it national governance, be it professional governance, or be it, industrial governance and accountability, because there are industrial standards for many things that we do, as we'll talk about in a second. And a big part of this is that explainable AI that I mentioned to you in a previous slide. That lies at the heart of responsible AI. And you can think about it like a black box recorder on an aircraft. So I enjoy flying planes. It's one thing I do. But if you have an accident on a plane, there's a black box recorder there that can tell you what went wrong. Okay, so you don't normally need to look at the black box recorder because it just records all the data that's coming from the plane, and you take the plane off and you land the plane. But if something goes wrong or something you don't expect, you can look at the black box recorder and you can say, well, what happened there? And that's what explainable AI is. It allows you to go back and get a feeling of what happened. It's one of the techniques we can use to look inside a model. There's other ways we can do it with weighted inputs, but we can start to figure out how a model came to that output, how that deep learning neural net developed its output. And then that leads us into another evolving area of AI called trustworthy AI. So can we trust the AI that's giving us that diagnosis? And that means we need to have trust in the model, which we just described, trust in the data, which we also discussed, and then trust in the process. So who's actually giving us this AI? Is there oversight to this? Like if you take a medication in the US, there's trust in the process of the FDA. In Europe, we have the equivalent with something called CE. So what's the process of delivering this to the end user? And that leads us nicely into regulation. And that's a really important topic to finish on when we talk about AI. Does AI need to be regulated? So I was fortunate enough to recently to be invited to the White House. It's a beautiful building built by an Irishman and an engineer. And in the White House, we have PCAST, the President's Council of Advisors for Science and Technology, and they have recently published a really good framework on AI in research and in deployment on planet Earth. I encourage everyone to read it if you look it up on the internet. And I had an opportunity to speak with them about AI in healthcare. And, one of the big questions is, should we regulate it or not? It's what everyone's asking. So, for example, if you regulate it too much, then innovation might go to countries that don't regulate it at all. However, if you don't regulate it, then it's a free-for-all. So you need to get that balance right. And the question essentially is a philosophical one: should you regulate something? And the answer is, I think, clearly when it comes to this and anything to do with humans is yes. So we regulate, for example, food. We regulate the quality of food. We regulate the way we drive. We regulate electricity. So we regulate things that can cause harm to us so that we can use those powerful forces in a way that's useful to us without putting us at danger. And I think that's a good way to leave this talk, that AI is going to be very powerful in medicine, very powerful in thyroid disease, but it needs to be developed responsibly so that we can have trustworthy AI and use it to all our advantages. So I'll leave it there. I want to thank you for your attention. Just leave Elon finish.
Hi, Derek. This is Elon Musk. This was a great presentation. I have learned lots about AI. Thanks.
So I want to thank Elon for that. And I would like to thank you for your attention. And I'll hand you over now to Dr. Guillermo.
Well, thank you, Derek. That was fantastic. I mean, well, as a matter of fact, I'm going to share my screen. And what I'm going to do is just to wrap up a little bit of what you already said, which is the responsibility that we have with artificial intelligence in healthcare in general, but in particular, I'm going to focus more to radiology too, because this is actually my background, and I will explain why radiology has to be the player here, and also in particular in thyroid. So, as Derek mentioned, what we have in medicine now is data, and in imaging in particular, because we are talking about the thyroid, artificial intelligence in thyroid, and although most of the time we as radiologists or in general as physicians or endocrinologists, when you think of that, you think about ultrasound, imaging ultrasound. As Derek mentioned, there are a lot of other things that happen with the patient, with data and the patient's multi-parametric data that can be combined and can be held and interpret in an artificial intelligence environment or algorithm in order to predict something. Remember that all these artificial intelligence architectural algorithms are just predictive machines. The idea is to predict something. So talking about responsibility, obviously this has to be transparent. The idea is trying to explain what is happening in our the way we could in this black box. As Derek mentioned, there are many things in which we don't understand how the algorithm goes to one of the outputs that eventually he's right. I mean, he's coming to the right answer or the right outcome of the patient, the right diagnosis, but we don't know how it got there. So sometimes it's because of the label, sometimes it's because of the marks or whatever, and sometimes it's because of the pattern recognition of the disease, which is what we already want. But anyway, we have to be careful in that. We have to do and to have ethical standards and guidelines, as you just mentioned, Derek, at the end of your talk, because we have a lot of bias. So remember that all these algorithms, they are trained with data. ChatGPT or whatever other algorithm that you can think of, they are just trained of our data that is in the net with all the bias that we already have, all the misinterpretation that we already have, all the everything. So we are looking now that artificial intelligence, even for example, in radiology, has a lot of bias. And the algorithm can detect if you just on CT and sometimes just on X-ray of the chest, if you are black or not, if you are diabetic or not. So if you are doing a CT of the abdomen, is going to tell you that you are obese, that you have liver fatty infiltration. So there are many things, many other biases that we can move from the training period of the algorithm, and then we will have the same complications and the same bias that we already have as humans. We are transposing that just to all the algorithms. The other question, which is very important, and Derek also mentioned, is that data privacy, okay? And for that, well, we need regulation, and he just mentioned that, and I do agree with that. As a matter of fact, Europe is probably ahead of the North America in that sense, in particular, if we think about all the artificial intelligence in general, and in particular in healthcare, I think also too. We eventually have to have the patient consent, and which is very important, and Derek also mentioned at the beginning of his talk, is interdisciplinary collaboration. I cannot enforce this more. This is something very important. This is not just a unique of one specialty or one person thing. Like the VIS example that he put, we have to collaborate. So the specific recommendations, because they were general for thyroid, is, this is going to be, I think is going to be great for accurate and early diagnosis, and to go forward in what we now call personalized medicine or precision medicine, for monitoring the follow-up with objectivity, because most of the times we are very, very subjective. And I have to say that in radiology, this is a very particular thing. We are used to say, well, there is a discrete thing, there is something like that, there is a small nodule. I mean, we have to quantify in order for doing follow-up, for example, and to be objective. This is going to be, because actually there are a lot of papers already now, that very helpful for patient education and support. And the artificial intelligence chatbots or algorithms can show what the patient in a way, in a graphical way, in a descriptive way, in a pictographic way, that the patient can understand. And if he understands, or she understands, obviously, this is going to have a better follow-up, a better treatment. And as always, and I already told you, well, ethical use and for diagnosis and treatment. In radiology in particular, I'm going to emphasize that, and let me tell you why. This is the FDA, this is from 2022. In October every year, FDA updates the list of the artificial intelligence. Artificial intelligence algorithm in the FDA is handled like a medical device. And well, you can see there, this is October, this is the last year, the most recent one, which is October 19, 2023. And what I want to emphasize in that is that 87% of all the devices that apply for approval of the FDA have to be with radiology. And there are many numeralia here, but basically radiology is handling. I mean, I know this is just copy, screenshots of, but did you see radiology? Radiology is heading all this artificial intelligence. There are pages and pages, and basically this is radiology. And if you see this picture, basically all of the specialties have to be eventually converted to radiology. So that's why, for me, it's very important that radiologists, we are aware that we need, as a recommendation for being responsible in using artificial intelligence, to have continuous education and training. This is something new. Derek spent most of his talk talking about data. And in radiology, that happened many years ago. When Röntgen discovered the X-rays, well, that was a kind of picture, okay? But when there was a transition to digital imaging, when Hansfield invented the CT, the computer tomography, he did something that probably he didn't realize at that time. But whatever is now is that imaging that is not a photography. Imaging are data. Every single pixel that also Derek mentioned, pixel stands for picture element, is product, is the way we display a voxel, which is a volume element. Within that volume element, either on CT, MR, ultrasound, contains a lot of information that we cannot interpret, our devices cannot interpret, but that artificial intelligence can. So we need to understand that we have to prepare for this new big data handled, okay? And we have to combine all these omics, which is genomics, proteomics, metabolomics. We also have now radiomics. And radiomics is a big part of that because imaging are data, okay? So for that, as Derek said, well, we have to collaborate with experts because this is not our typical field. We have to integrate that in our clinical work. One of the best advices that everybody tells you is if you want to handle and to get involved with artificial intelligence, use it. Use it every single day. So and the more you use it, the more you get accustomed to that, and you see what is good for and what is not good for, okay? We also have to validate data, as Derek mentioned, because one thing is when we train one of the algorithms and in one specific setting with one specific machine, with one specific imaging protocol, but when we move that to other environments, this not always is as good as is for in the area in which it was invented, discovered, or prepared. And don't forget about the patient-centric. So this is for radiologists, but for radiology practices, which you are involved as endocrinologists, you eventually need, or even for your practice, if you are going to have infrastructure, you need a system like a PAC system, like an algorithm. You have to invest, okay? You have to implement a very robust data security measurements. As Derek mentioned, you need governance protocols, standardized protocols. And also we have to monitor, because this is something, one of the main characteristics of this new technology, of this new tool, artificial intelligence, that is learning, continuous learning. So we have to reevaluate continuously, evaluate the AI performance. And as always, I told you, we have to engage interdisciplinary collaboration. And I think this is going to be great for patient education and, well, obviously for the future. So in particular for thyroid disease and radiology, and the recommendations that I would say for the responsibility is this is going to obviously enhance imaging analysis. We can, with this tool that can handle this immense amount of data, personalize follow-up plans, which is very, very important, personalized medicine. Not every single patient, although has the same disease, is going to respond exactly the same. In our case in particular, I'm interventional radiologist, as Camilo said, but even you as endocrinologists, we as radiologists, the way in which AI can help us in analyzing thyroid biopsies and to make a prognosis and of how the patient is going to have the outcome eventually. I think this is going to be one of the main reasons for doing that. And obviously we have to be involved in research and development, because this is something that is just beginning and is going to be very important. And with that, I want to thank you.
I want to thank you both, Dr. Elizondo, Derek, for carving out some time this Friday. First, before I jump into my first question, I would want to encourage anyone in the audience, if they have any questions, please send them this way so I could replicate them and ask them to our our guest today. First of all, I want to, if I may, editorialize a little bit. I think one of the things that most of us in the call here were enthusiasts in what this science and what this new technology encompasses, but we're a little scared of what can happen if we don't use it responsibly. So Derek, in his lecture, he spoke about GIGO being the Google garbage in, garbage out phenomena that we have, and how we are so scared of this black box phenomenon where we feed an algorithm something and it spits out something that might or might not be useful. And when we speak about artificial intelligence, both Dr. Elizondo and Derek, you might be familiar with the Turing test, which is the test that we put any algorithm through to say if it's a valid response or if it's as good as a human to evaluate any given task. So that's our biggest worry. And we worry about it a whole bunch in healthcare, but we don't worry about it when we think about driving to school and using Waze or Google Maps while we do that. You don't dare defy the Google Maps to go to school, because if you do that, you'll arrive later in that day where if you're driving. But when it comes to healthcare, we always have that tendency to think that we're bigger, we're smarter than a computer. And we might be, because we have intuition, we have no consciousness, and the machine might not have it, as Derek was mentioning before. So what do we do to close that gap? We don't want the machine to, as the Terminator, to wipe out the doctors of the world, but we definitely want to have tools that make us predict, that make us diagnose, that make us maybe use this. I've heard Derek speak about this in the past, where we can have a tool that we train and we can extrapolate it to a rural space in Kenya, or even in Mexico, or in, I don't know, far in Canada, I don't know. But that would be amazing. How do we close that gap? How do we use big data? How do we bring it there? And what do we do if we don't have big data? I understand collaboration, and I understand there's also mathematical statistics that we could use as, like, for example, SMOT, when you have small data and you synthetically can extrapolate that to begin a big population. But how do the users in this call, how do the listeners in this call, and I might just give you a minute there to answer, how do we start to use data in artificial intelligence in our field? Derek?
Yeah, thank you. So great question. Thank you, Camilo. So couple of things. So first of all, if you were to think about resources, so things get solved when there's resources put into them, right? So if you were to think about all the AI engineers on planet Earth and all the compute power, how much of that is spent on healthcare? And I would argue it's probably very little at the moment. Most AI research and indeed resources are going into commercial things in industry, like I said, the Alphabets, the Googles, the Meta, Facebook, Amazon's, Microsoft's. Most of the AI research they're doing is for commercial products for financial gain, because that's the world we live in, the capitalist model. So the first thing that has to happen is a lot more resources has to go into healthcare AI. Most of what's done at the moment is actually in the academic world, where you do have people who are MD PhDs or clinicians who have an interest in science, who see the potential of those tools that the other people are using in healthcare. And you can see that Dr. Guillermo showed there's probably only 150, 200 products in AI in healthcare at the moment. How many apps are on the App Store? There's probably something like, 500,000 or 1 million of them, because that's where the money is. So that's the first thing that has to happen, is that resources has to go into it. So resources will come in when there's money in it. And that's why, as I mentioned, in the last 20 years, the big commercial companies have gone after the data that's in banking and shopping. They're coming for healthcare next, for sure, because healthcare has the most data, and then you can use that data to make financial decisions like, how much you're going to charge somebody for their insurance policy, or indeed, type of treatment you might offer them. So all the big companies that we mentioned, the data companies, they're starting to move into this healthcare space. We're going to see a rapid explosion of AI use cases from the commercial companies. And one of the big challenges they have immediately, and you mentioned this already in your question, is the data sets. So we're not very good in medicine at data sets. First problem we have is most of the world doesn't have digital records. They use papyrus. They still use paper to keep their records. And those who do have it, they tend to have it in different digital islands. So they have one computer for labs, a different computer system for radiology, a different computer system for EHR. So there's very few practices outside the US and maybe the developed world that has that volume of data in an integrated way, that you can see the labs with the radiology, with the text from the clinical record. And that's a challenge. So when you start trying to understand that, that's what we need to do. And then, of course, we've introduced HIPAA in the US and GDPR in Europe to protect privacy and data, which is super important, as we all know. But in some ways, they're so protective. All the data we've collected to date can't be used unless express permission has been given. And a lot of those people who've given that data, or at least that we've collected that data, they might have RIP'd by now. So all that data won't be used. So we need to come up with better mechanisms to protect privacy, which is very important, but to de-anonymize the data and to give almost an opt-in policy rather than opt-out when you are collecting the data at source. So they always say, when's the best time to plant a tree? And the answer is yesterday, right? So it's a bit like that with the data. So going forward from this date, we're going to start collecting data. You have to opt out if you don't want it to be used. And either way, it's de-anonymized at source for research purposes. That's the kind of big thinking we're going to need to have to get enough accurately data for healthcare AI. And just to answer your first observation, when you mentioned why you use Waze or Google Maps or Apple Maps to go to your school, and you drive your car accordingly, it's because you trust it. And that's a huge part of AI. And that's what I was saying. It leads into trustworthy AI. The minute we start to trust things, we start to take them into our world. So we trust an MRI to give us a reading, and therefore we do it, and we have it as part of clinical practice. AI isn't there yet. It'll take a couple of years for us to trust AI enough to understand that it's been developed in an ethical and legal way for us to trust it, and then implement it in medical practice. Because medicine, out of all the domains that humans interact with, is probably the most conservative for good reasons, because we don't want to have us do something that causes unintended consequences. So AI has a long way to go before it's accepted in mainstream clinical practice. And I'll hand over now to Dr. Elizondo.
Well, I think Camilo and you, Derek, you mentioned some very important things. I'm going to move a little bit, just not to repeat the same approach, but taking something that Camilo mentioned, and this is true. You have to think the other way too. Remember that we are patient-centered now, okay? And from the patient's perspective, because it's people, patients are we are patients. When we in our lives, we hear and we use artificial intelligence apps, we trust them, as you said. we can basically, if you go to a bank, if you go to an airline, if you go everywhere, and they tell you that they are using artificial intelligence, you as a customer, as a patient, or as a human being, you feel better because you think, well, they have a high technology. This has to be better. So I think very, very short from now, in the few years, people, that means patients, are going to ask you if you are using artificial intelligence for their care, okay? Because they think that this is better, although we could understand that this is not exactly the case. But this is, again, money. This is going to be pushed, I will say, from society to use that kind of tools also in healthcare. So they will come to the Department of Radiology and they will ask us if her mammography is going to be read by artificial intelligence algorithm or something like that. Okay, so they are starting to ask that. So because this is something that is going to happen. So answering to Camilo's question is yes, I think we have to accept that this is something that is happening, as Derek mentioned. Compared with the other part, I mean, not only is a very small amount of money put in healthcare in artificial intelligence compared with the rest, but if you read between lines, in medicine in general, almost 90% of the money is in radiology. So the idea that artificial intelligence is taking care of healthcare, of medicine, this is not the case. Okay, the rest of the specialties are not even represented in the FDA application forms for devices or for artificial intelligence algorithms. So this is going to take some time. And the other part, just to close that part, at least in our part from radiology, is that for me, okay, I can feel some confidence in reading an X-ray, an MR, and tidal ultrasound. But remember that there are many, many, many places in the world where there is not a single radiology. Even in the United States, there are countless counties that the patient, they don't have a single radiologist, okay? They have to travel miles. So in that sense, if the general physician, if the family physician has an application that can help him just to be sure that the X-ray, that the patient doesn't have a fracture, that there is no pneumonia, that there is no pneumothorax or something like that, this is going to assure him that his appreciation is just validated by another app. So I think this is going to be moving. We have to learn and to be part of this, as I always say. If we want to move the train, to handle the train, we have to be in the train, we have to drive the train, okay? Because I don't want just to pass the train, okay? I want to be in the train and driving the train. Thank you.
Correct. So learn, collaborate, and trust. I can't thank you enough for your time this morning. I can't thank our audience enough for being here, sharing this morning with us. I want to invite you all to come back, not next week. Next week, we have the 4th of July holiday, but the following week, we'll have a lecture by Dr. Luke Morris on active surveillance and tumor volume kinetics. So we'll see you then. Hope everybody stay safe and stay happy. Take care.